Hey, can you hear the sound? Okay, it's a 30-minute show of a CMS from internal medicine. Hope you will enjoy this journey of internal medicine. Start. So this patient has acne vulgaris. This patient has acne vulgaris. Look at the acne vulgaris. So we know that in acne vulgaris, if somebody wants isotretinoin, which is a vitamin A derivatives, like this patient, talking about the isotretinoin. Isotretinoin therapy is contraindicated in these patients because of which of the following historic findings: sexual activity without contraception. Sexual activity without contraception. So as she, because isotretinoin is very teratogenic, if she becomes pregnant and she is not taking two forms of contraceptives, then it may cause serious teratogenic effect on the baby. So that's why. So next, now these question, this question, synchronized cardioversion should be done. Synchronized cardioversion. There is a wide complex tachycardia. So patients with the wide complex tachycardia require emergency medical attention and intervention. Rapid. Wide complex means, what does the wide complex means? That means the QRS duration. That means the QRS duration is more than 120 millisecond. The QRS duration is 120 millisecond. So wide complex tachycardia, uh, QRS duration more than 120 millisecond, looks like ventricular, looks wide complex tachycardia has multiple cause. So the most important talking in this perspective, if somebody comes with a wide complex tachycardia, rapid electrical bipolar or a wide complex tachycardia requires emergency, required immediate synchronized cardioversion, require immediate synchronized cardioversion to abort the symptoms and permit the cardiac output. So ACLS protocols as established should be immediately cardioverted, stable perfusing wide complex arrhythmia can be treated with antiarrhythmic drugs, as well as any patient with pulseless wide complex tachycardia or ventricular fibrillation should receive cardiopulmonary resuscitation and be defibrillated. Next question. This patient, why medial degeneration of the aorta? So, a history of chronic hypertension. This patient has a history of chronic hypertension. A history of chronic hypertension, if poorly controlled along the acute tearing, this patient has acute onset ripening substernal pain, sudden onset ripening substernal pain. His BP is very high, 220 over 128. So it is hypertensive emergency in both arms. Cardiac, radial, femoral, and pedal pulses are within normal limits. A chest X- a chest X-ray of the a chest X-ray X-ray, sorry, an X-ray of the chest shows widened aortic root. So widened aortic root and dilated ascending aorta. Dilated ascending aorta looks like aortic dissection. So aortic dissection, the pathophysiology is medial degeneration of the aorta. Medial degeneration. So history of chronic hypertension, polygon control, the tearing of the tunica intima and media, tearing of the tunica intima and media, tearing of the tunica intima and media. Dissection allows the creation of the false lumen, where blood can accumulate, where blood can accumulate. So there is cystic medial necrosis of the aorta, cystic medial necrosis of the aorta, and this process occurs predominantly in the tunica media. So the smooth muscle layer of the arterial wall and results in progressive weakening leads to increased thoracic aortic aneurysm, and dissection. Okay, the activation of the mast cell looks like asthma. So this patient activation of the mast cell, as it is asthma, we know the pathophysiology of the asthma. There is activation of the mast cell. The features look like the asthma, tight sensation chest, non-productive cough, tight sensation, non-productive cough. The cough occurs most frequently in the night after she goes to the bed. She said she received breathing treatment. So these and that. So looks like asthma. Okay, next. So this patient, 50-year, feels faint, cold, sweaty. Looks like hypovolemic shock. Hematocrit is low. So give blood. So rapid infusion of iron and percent sodium chloride is the most appropriate in the management of patients decompensated hemorrhagic shock. So for patients decompensated hemorrhagic shock, first is to fluid. In acute blood loss, so this patient has massive hematemesis. So this for this acute blood loss, you need to give fluid first. You need to give the fluid first. So in hemorrhage, we know that both RBC and in hemorrhage, both RBC and plasma are not lost equivalently. This results in normal hematocrit, though overall blood volume is decreased. So we should not be confused we should not be confused seeing the hematocrit level. Yes, in hemorrhage, both RBC or plasma are lost equivalently. This results in normal hematocrit. Okay, option 6. Uh, okay, this patient, why it is high output cardiac failure? Because okay, why it is high output cardiac failure? In high output cardiac failure, look at the hemoglobin. So anemia, anemic heart failure. This is the cause of the anemic heart failure, and this thing, heart failure easily can be assessed like H3 gallop. So it's heart failure as the patient has anemia. This anemia is causing the high output cardiac failure because as there is severe anemia, the heart must increase the cardiac output. My heart must increase the cardiac output and increase the heart rate and potentially in stroke volume and so delivery and delivery. mm, in If oxygen content falls, cardiac output must rise to maintain equivalently. Cardiac output must rise equivalently. That's it. Okay, look at this question. So here's some sort of traveling history. Watery, non-bloody diarrhea, traveling history, water, non-bloody, but foul smelling. This makes you confused. It's a foul smelling. But as it is traveling history, so go straight simple. ETAC, enterotoxigenic E. coli, enterotoxigenic E. coli, because the rest of the cause usually bloody or some sort of watery diarrhea. So there is no traveling history. So traveling history most common is ATAC. Next question, option 8. In DKA, I have a In DKA, there may be low bicarbonate. In DKA, bicarbonate is very low. Low bicarbonate, high glucose. In DKA, presence of ketone body. So the ketones will be present. Accumulation of the beta hydroxy butyric acid. DKA is the accumulation of the serum ketone such as beta hydroxy butyric acid and acetone in the setting of the deficient of insulin signaling. It is regulated fatty acid degradation and ketone synthesis occurs because of relative state of starvation created through the absent insulin signaling. Patient presents with fatigue, urea, this and that, and lab shows increased glucose, ketone, and high anion gap metabolic acidosis. Anion gap is okay. That's it. So next question. So this patient PTT is higher, greater than 120. Platelet count is low. 3 hour history of muscle swelling. 3 hour history of muscle swelling. Low platelet. 3 hour history of muscle swelling. PTT is higher. Looks like hemophilia. Hemophilia is X-linked coagulopathy. The X-linked coagulopathy arises from a genetic deficiency. Mm, Genetic deficiency, and the bleeding time is the other option, the measurement of the bleeding time. Why we're doing bleeding time? Bleeding time is a measure of the platelet function. Bleeding time is a measure of the platelet function and is used to diagnose the platelet disorder. Bleeding time is a measure of the platelet function and is used in the diagnosis of the platelet disorder like thrombocytopenia, von Willebrand disease, disseminated intravascular coagulopathy, Bernard-Soulier syndrome, glandular thrombosthenia, these and that. Okay, next. So next question in here, the answer would be the osteosarcoma. Why osteosarcoma? This is the right answer, osteosarcoma. We know, we know that chronic pain, bony swelling, history of chronic pain, bony swelling, history of malignancy in childhood, like retinoblastoma in childhood, history of malignancy in childhood, raises suspicion for a diagnosis of the osteosarcoma. Very, very high yield word is you have to remember. Don't go for high LP. We know that isolated LP more than 60, 65. Go for Paget's disease. That's why I have go through the Paget's disease. But this patient has what? This patient has a history of malignancy. So this patient has a history of malignancy. Uh, so this patient has history of this patient has history of malignancy. History of malignancy. History of malignancy, chronic pain. This patient has history of malignancy, chronic pain, and bony swelling. Malignancy, chronic pain, bony swelling. Go for, go for osteosarcoma. Osteitis deformans, which is also known as Paget's disease, presents in the breakdown, remodeling, and disorganization of the newborn deposition, results in deformity, pain, fragility. It is rare in youth. So 23-year osteosarcoma, very unpredictable, but underlying malignancy, history of malignancy, chronic pain, bony swelling, go for osteosarcoma. Okay. Next, uh, this is pertussis. Pertussis is episodes of so intense, like the cough was worsened, like the cough has worsened an episode so intense that he was intense cough. The cough was worsened episodes so intense that he has vomited. The cough is productive, thick green sputum productive thick brain. So episodes of severe coughing followed by emesis in the setting of the respiratory illness raises suspicion of the pertussis. Pertussis is caused by infection of the bordetella pertussis. Bordetella pertussis. Symptoms resolve convalescent phase stage which lasts 1 to 4 weeks. Pertussis can be prevented with immunization treated with antibiotics, typically macrolides. Okay, next is ceftriaxone or why ceftriaxone. Why ceftriaxone? So this patient has pneumonia, bronchial breath sound, egophony. These are the features of the pneumonia, hypertension. So pneumonia is severe. Normal pneumonia outpatient management can be done, but if the patient has hypertension confusion, go for hospitalization, fever, shortness of breath, cough, productive yellow brown sputum, focal pleuritic chest pain, toxic these and that, consolidation. So lobar pneumonia, streptococcus pneumonia, hemophilus influenza, morrison catarrhalis, staph aureus. Antibiotics should be given. Antibiotics should be given. Okay, next. This is clean card anaphylactic shock. Anaphylactic shock. Clean card anaphylactic shock. The next question there is a measurement of serum immunoglobulin, measurement of serum immunoglobulin concentration, the history of sinopulmonary infection in otherwise healthy, and in other sinopulmonary infection in otherwise healthy adult with the thrush raises possibility of the late presenting primary immunodeficiency. So, multiple sinopulmonary infection in an otherwise healthy infant with a thrush raises suspicion of CVID. CVID. C. So, this patient mild shortness of breath, cough, productive. So, this patient cough, productive yellow sputum. Multiple she uh she has 20-year history of multiple respiratory tract infection. She has 20-year history of multiple respiratory tract infection, episodes of pneumonia during the past 15 years, 2 episodes of sinusitis, pneumonia, 2 episodes of sinusitis require antibiotic therapy for bronchitis. They are 3 to 4 times yearly. She has mild lymphadenopathy, and there is mild oral thrush. So mild oral thrush, repeated infection, a measurement of the serum immunoglobulin for CVID. So this patient has labyrinthitis. Why it is labyrinthitis? So this 42-year-old woman is brought to the physician, 3 day history of dizziness and gait instability. Dizziness and gait instability carried a broad differential. These symptoms, central, peripheral, and secondary causes of the cerebrovascular, secondary causes are to determine like diagnosis. There are some central causes or two. So vertigo has multiple causes: central, peripheral, vertigo. Peripheral vertigo has BPPV, labyrinthitis, meningitis, endolymphatic fistula, temporal bone fracture, tumor lesion. Uh, Central cause are stroke, tumor of the brainstem, cerebellum infarction involving the vestibulocochlear nerve, multiple sclerosis, or similar demyelinating disease. And peripheral causes BPPV, labyrinthitis, meningitis, endolymphatic fistula, this and that. Mm, Labyrinthitis is the inflammation of the inner ear involving the vestibulocochlear nerve, inflammation of the inner ear involving the vestibulocochlear nerve, and is often preceded by an upper respiratory ear infection. Classic symptoms include vertigo, ataxia, nausea, hearing loss. Treatment is supportive. Supportive. It's not acoustic neuroma where there is central vertical impingement of the vestibulocochlear nerve at the brainstem. These tumor often cerebellopontine angled and often subclinical. There is an association. So acoustic neuroma is associated with neurofibromatosis. So that's it. In acromegaly, we know that serum IGF growth factor 1 should be done. If diagnosis clinical, surgical resection is the preferred treatment. In acromegaly, surgical resection is the preferred treatment. If surgery cannot be performed, somatostatin analog, octreotide, and antagonist like growth hormone receptor, pegmisuman can be used. Pegmisuman can be used. So this is asbestos. Asbestos, a history of working in the shipyard. History of working in the shipyard look like asbestosis. So shipyard worker is asbestosis. Uh, a history of working in the shipyard, chronic cough, shortness of breath, pleural effusion, plus calcified pleural plaque, suspicion of malignant mesothelioma, exposure to asbestos in the shipyard. Shipyard exposure to asbestos in the shipyard is the most common risk factor. Pleural fluid analysis characterizing markers in the pleural fluid can narrow the diagnosis and can and negative prognostic indicator. And pleural fluid pH and glucose are the markers of the cell metabolism. Cell low pleural fluid glucose indicates increased cell metabolism, and negative prognostic factor in mesothelioma and in mesothelioma. Okay, now next. So this patient has pulmonary edema and X-ray show cardiomegaly, cephalization of the pulmonary vessels, S3, JVD distension, crackles on the lower. So shortness of breath, edema, JVD distension, crackles, dependent cause areas of the lung, history of the poorly uncontrolled hypertension, tachypnea, tachycardia, X-ray show cardiomegaly and cephalization of the vessels, raising suspicion of the cardiogenic pulmonary edema because of increased pressure in the left side of the heart, pulmonary vein, pulmonary capillaries. Pulmonary edema can also occur from non-cardiogenic sources, acute respiratory distress syndrome, multifocal pneumonia, burns, inhalation injury, high altitude drowning. Because of increased left heart filling pressure in the heart failure, the pulmonary venous pressure rises, which in turn results in increased pressure in the pulmonary capillaries. Nitroglycerin is a vasodilator, can be utilized to shift fluid into the capacitance vessels and lower preload. Positive pressure ventilator can be used. Positive pressure ventilation can be used to reduce alveolar, can be reduced to can reduce alveolar and interstitial edema and drive fluid back into the circulation. Treatment is through diuresis to reduce the patient's hypervolemic state and lower cardiac filling pressure. Okay, ceftriaxone should be given. So a previously 22-year-old physician, 2-day history of fever, chills, abdomen soft, RBC, WBC is high, RBC is also high. So this patient has 2 days of fever, chills, and left flank pain and vomited. So looks like pyelonephritis. If RBC is high and fever is high, left flank pain, vomited twice, BP is going down, IV ceftriaxone should be started for so for acute cystitis, this should be given. Okay, this is nephrotic syndrome. And nephrotic syndrome. Why it is not other option? Nephrotic syndrome causes edema due to this patient 27 face and legs, 2 weeks, facial swelling, pulse, blood pressure 110/70, cardiopulmonary examination shows no abnormality. There is pre-sacral edema 2 plus edema of the lower extremity, edema 2 plus lower extremity, and prothrombin time is 12 per second. Okay, that's the 20 questions of the internal medicine. I will catch you later. Hope you enjoy.